시청자 여러분 안녕하세요.
Greetings, this is Prosthodontics on Friday, which addresses different steps in implanted treatment as well as side effects. Today we have with us Professor Seo Jae-min of Jeonbuk University Prosthodontic Division. He's going to talk about abutment and prosthesis design as well as biological failure. Greetings, thank you for inviting me. I'm sure you're busy treating patients and doing research. Thank you for coming all the way to provide a lecture. I'm honored to have you here. I believe the prosthesis design is something that a lot of dentists can overlook. Thank you for emphasizing that. Before we go in, can you briefly explain about your lecture? As mentioned, today I'm going to talk about the design of implant abutment and prosthesis. There's no set consensus as to what kind of design is better in terms of implant prosthesis or abutment, because implant is not natural teeth, it is artificial teeth. There are limitations to imitate natural teeth. If you think outside the box, there can be areas where you do not need to imitate the natural teeth. Various concepts exist when you make an artificial teeth, and they have pros and cons. In some cases, consensus may not be necessary or it is not achieved up until now. However, there are certain forms that cause problems in common. Today in my lecture, I'm not going to give you a definite answer as to what the ideal abutment or prosthesis should look like, but I'm going to talk about cases where it led to problem. Of course, I'm going to also address the designs that I like. I'm going to talk about my clinical experience primarily. Thank you. After listening to your brief explanation, I look forward to your lecture even more. Thank you. Those of you watching the program from dental site, you can communicate real-time via the chat screen. Leave your questions, and through a lucky draw, Starbucks coffee coupon will be sent. Also, best question will be selected and 3 Starbucks coffee coupons will be sent. Study your implant prosthesis design and get Ice Americano coupons. Only those who agree to marketing in dental site will be able to receive the coupon. Please note this and win your coffee coupons. I look forward to your keen interest, and let us begin Professor Seo Jae-min's lecture. I am Professor Seo Jae-min of Prosthesis Division at Jeonbuk University. Today I'm going to give a lecture on design of abutment and prosthesis. I'm going to focus on clinical cases. This is not going to be academic, so I hope you stay tuned. The contents can be divided as shown. They're practically the same, so you can think of them in one big picture. Mesiodistal appearance. Number 47, the patient's chief complaint was food impaction around the implant. If you look at the contact, it's okay, but if you look at occlusal view, you can see the cause. Number 46, on the distal side, there is bulky resin restoration and the proximal contact was too tight. If the proximal contact is too tight, it leads to fibrous food to wedge between the teeth. You can see undercut here on the mesial side if you look at gingival embrasure. If you reverse the prosthesis, you can see the cause even more. The implant has been placed slightly distally. And because the stuck abutment was used, the emergence angle of abutment and distal contour of the prosthesis did not match. Therefore, there's undercut in this area. I think the lab technician did his or her best to prevent impaction. I think the prosthesis was intentionally made concave. If you make this convex, there's an even clearer undercut between abutment and prosthesis. And if there's food impaction here, it doesn't come off. I think the lab technician thought long and hard and made it concave. However, you can see food in the concave surface. The patient finds it uncomfortable. There is a consensus on natural teeth, but there's not much regarding implant. In the case of natural teeth, the mesiodistal contour is flat or slightly concave. It's never convex. How about the implant? The size of implant body is smaller than that of natural tooth's root trunk. The emergence angle of implant is compared to natural tooth. It's slightly more drastic. It is more slanted. That being said, if the mesiodistal appearance of abutment and prosthesis is concave, the space with gingival embrasure becomes too much and it becomes concave with the mesial side slanted, leading to even more food impaction. Unlike the implant, the natural tooth is basically vertically upright mesiodistally. Therefore, even though it's slightly concave, food impaction does not occur frequently. However, in the case of implant, it is slanted, and if it becomes concave, that's where food impaction occurs easily. Conversely, if it becomes convex, gingival embrasure space becomes smaller. I'm going to explain once again later, but this can invade the soft tissue space. This area, please take note, between the implant and abutment, clear undercut can be formed. Therefore, I believe concave form is periodontally negative. The contour of implant abutment and prosthesis should be flat. This is best, and what is important is the emergence angle of the abutment and prosthesis. It needs to be similar. It needs to be naturally transitioned without undercut, hence the flat contour. As mentioned, implant diameter is smaller than that of natural tooth, so basically the gingival embrasure becomes bigger because the proximal contact becomes more horizontal. You need to explain this to your patient so that patient can accept the results. In the front teeth, the bulky resin restoration was adjusted to have normal contour. I made a prosthesis with adequate proximal contact. The key point here is the abutment and prosthesis needs to be made so that the transition from implant platform to proximal contact can be made natural. The patient was very happy. There's another reason why the transition from abutment to prosthesis is important. I'll show you this case. In the case of this case, implant was placed by another doctor and I did the prosthesis. The implant was slightly distally tilted. Frequently, problem occurs on the mesial side. If the implant is placed in a tilted manner on the other side, the emergence angle of abutment or prosthesis becomes extremely slanted and the problem occurs. I'll mention this later. What is important is that I made abutment nicely. However, in this case, the prosthesis was over-contoured and undercut occurred in between, leading to food impaction. So this is what I've missed. This is a different case, number 15 and 16, between the implants. The patient was experiencing a lot of food impaction. That was the chief complaint. If you look at the interproximal contact, the strength is okay, but if you put in the floss, the contact is made not in occlusal third, but middle third. In other words, food becomes impacted in the occlusal embrasure. Therefore, contact point is very important. If the contact point is inferior, the vertical space from the implanted platform to the contact point becomes reduced, leading to even more horizontal emergence angle of abutment and prosthesis. The vertical space is lacking as is, but if you use small diameter abutment, the prosthesis, in order to compensate for the small diameter, the emergence angle becomes more drastic. This leads to undercut in between abutment and prosthesis, and that's where food impaction occurs. This is a study I reported to an academic journal. If all have a subgingival margin, cement removal occurs most easily in A. In the case of B, there's undercut between abutment and prosthesis. The cement removal is not easy. In the case of C, because the emergence angle is too excessive, the cement removal using Explorer is not easy because it goes in horizontally. It does not have good access. For cement removal as well as prevention of food impaction, I believe A option is the best. I'm sure you have your thoughts and philosophy on abutment and prosthesis, but I would like to tell you my personal opinion. I believe a flat is most ideal. Convex, I do not recommend this because this can pressure the softer tissue and deviate the softer tissue buccally and apically. In aesthetic area, unintentionally, margin can be exposed if the softer tissue is thin. In this area, the abutment can invade the softer tissue space. This can lead to chronic inflammation or bone loss. I'm going to explain this later in detail. If the abutment is convex or concave in this area, undercut can occur, so this is not recommended. But in the case of interior buccal area, this pressures soft tissue less and deviation occurs less frequently, and you can get thicker, softer tissue. Therefore, in the case of anterior buccal area, this is recommended. I'm sure all of you know, but if there's natural tooth mesiodistally to an implant, the alveolar bone can be superior to implanted platform. In this case, if you use concave one, the pressure on alveolar bone can be reduced and there can be less patient pain. So this is recommended in those cases. This is my peer's mother. In number 47, there was a severe food impaction as well as bad odor. The patient wanted to solve this issue even if it meant removing the implant. As you can see, the emergence angle gap between the abutment and prosthesis was too significant. This led to undercut and food impaction. This leads to eventually chronic inflammation. The fundamental problem of this case was lack of vertical space due to protrusion of antagonist. If there's lack of vertical space, the abutment, prosthesis, and emergence angle becomes excessive. If you use a small diameter abutment, the emergence angle of the prosthesis becomes even bigger to compensate for that, leading to food impaction. In the case of this case, there was secondary caries in this tooth and prosthesis in the upper was removed and vertical space for the lower implant was secured. And after that, I made a design so that the emergence angle of abutment and prosthesis can be naturally transitioned and harmonious. The same lab technician should design the abutment as well as prosthesis at the same time. As for this study, this was from 2018. The study reports that emergence angle and contour of implant abutment and prosthesis is correlated with implantitis. If you look in detail, if the emergence angle is bigger than 30, compared with the group with less than 30 degrees, implantitis occurred meaningfully higher. If the contour was convex and emergence angle was over 30, most implantitis occurred. Just for fun, I measured the emergence angle of Ostem's healing abutment. The height is 5 mm, diameter is approximately 7, and it's approximately 37 degrees. Diameter 6, it's about 25 degrees. Diameter 4.25, it's about 13 degrees. This is the clinical information that you can bear in mind. Implant was placed problem-free, it seems, in number 16, but you can see that soft tissue thickness is too thin. I just added a big abutment and prosthesis to complete the case. Just 3 months later, the patient complained of soft tissue pain. So I provided perio treatment about 2 times, but conditions did not improve. When I removed the prosthesis, the palatal soft tissue is swollen and there's chronic inflammation. If you look at the prosthesis, the implant is slightly placed buccally, and I provided a big crown. Therefore, the palatal emergence angle was almost 60 degrees. When I took x-ray, you can see that there's bone loss around the implant. This needs to be redone. I adjusted the palatal emergence angle, which pressured the palatal area, and a prosthesis needs to be made as well as the abutment. I merged the existing abutment with the new one. Luckily, the emergence angle of the existing and the new are the same, but palatally, the emergence angle decreased from 60 degrees to 35 degrees palatally. Therefore, the palatal surface needs to be reduced palatally. After providing a new prosthesis, the pain disappeared dramatically. This is a case I did around 2010. At the time, I was infatuated with the concept of making implant as similar to natural teeth as possible. So I made abutment big in all cases and slightly convex. I made prosthesis big like natural teeth. I no longer do this these days. In this case, I did the same. The implant is placed shallow, and on top of implant platform, the soft tissue thickness is very thin, and I used a abutment with big emergence angle and convex form. With time, you can see that there's surrounding bone loss. The patient took diligent care of the teeth, so the bone loss discontinued after a certain while. The oral hygiene was extremely well maintained. This is because this study is by Professor Lind. The study is about height of soft tissue and surrounding bone of the implant. There's one group with a 4 mm of tissue thickness and another group with 2 mm tissue thickness. In the end, with time, the tissue thickness between the two groups becomes similar. In other words, if the soft tissue thickness is too thin, in order to secure soft tissue thickness, bone loss can occur. If you look at the review studies, they continue to emphasize the importance of soft tissue in surrounding area of an implant. In the case of patients with thin soft tissues, if you use abutment with convex contour and drastic emergence angle, it can pressure the soft tissue, leading to bone loss in surrounding bone to secure soft tissue thickness. That's my personal opinion. Fortunately, in the case of this patient, the patient had good oral hygiene. Therefore, bone loss occurred only to the level soft tissue thickness was secured, but if the patient has bad oral hygiene or if there is food impaction, it can lead to peri-implantitis. Let's look back in the study of 2018. The convex and big emergence angle leads to poor oral hygiene. Plaque can accumulate easily, and the possibility of implantitis goes up. I entirely agree. I would like to add one more thing as mentioned. Such contour can excessively pressure the soft tissue or invade soft tissue space. In conclusion, convex or big emergence angle can have negative impact in surrounding tissue. As mentioned, if implant has been placed in a tilted manner, it can cause many biological problems as well as mechanical problems. Accurate implant placement is really important. If the implant is tilted, when you design abutment and prosthesis, you need to pay more attention. You need to make sure that the emergence angle on the other side does not become excessive. For instance, if it is tilted buccally, you need to make sure that the emergence angle on the palatal side does not become excessive. If it is tilted mesially, you need to make sure the emergence angle on the distal side does not become too big. If the implant is buccally inclined, the occlusal surface and the contour on the palatal side needs to be reduced somewhat. If it is tilted mesially, the emergence angle on the distal side should not become big. Therefore, the gingival embrasure on the mesial side, you need to accept that it's going to be big. The deeper you place the implant, the emergence angle of abutment and prosthesis becomes smaller. Therefore, if there's lack of vertical space or lack of soft tissue, it is better to place the implant slightly deeper. This case is a father to one of my peers. The patient received an implant in number 47 a while ago, and the patient was complaining of swelling. Moderate to severe peri-implantitis can be observed. If you look over here, it has all the prosthodontic conditions for peri-implantitis. Implant is placed buccally and distally. The vertical space is lacking. Tissue level implant was placed and the platform diameter is 4.8, not 4.6. In this case, prosthesis emergence angle becomes very drastic because the implant is placed buccally. The emergence angle on the lingual side becomes quite excessive. If it is placed buccally, you would think there will be resorption of buccal bone and peri-implantitis around that, but if you actually look, there is peri-implantitis on the lingual side due to food impaction. In the case of this patient, I thought long and hard and I decided not to remove the implant because even if you remove it, it's going to be quite difficult. So I did reconstructive surgery. I redid the prosthesis. The lingual side was reduced. The patient is continuing to use it well, but the implant placement depth or angle, implant type cannot be changed. So there is possibility of recurrence. If there's excessive vertical space, there's higher possibility of mechanical complication. But if there's lack of vertical space, there's higher possibility of biological complication. Therefore, the smaller the vertical space, we need to pay attention to implant placement position. I would like to raise a question here. In the middle of your slide, in the X-ray, mandibular canal looks a little bit lower. If we place implant deeper, as mentioned, the emergence profile angle and embrasure space can be reduced. I think it would be better. A lot of experts emphasize placing implant deeper. Professor, so what do you think? I really agree. I agree 1000%. As mentioned, if you place implant deeper, emergence profile angle becomes reduced. Therefore, it reduces stress on the soft tissue and it prevents severe food impaction and prevent emergence angle from becoming too big. It's good in that end. What is best is, before you do implant placement, remove alveolar bone vertically first and place the implant deep. If there is sufficient height, yes. Even if the implant body becomes shorter, that is better. Because if you just place it deep, at times, if the alveolar bone thickness on top of platform, if it is thick, it is not resorbed automatically. And when you make abutment, it may be narrow in the lower side and it becomes much wider on the top. Or even if you have placed it deep, if you look at the patient's oral cavity, the vertical space may be lacking because there's not been any gingival resorption. In this case, remove alveolar bone from the start and place the implant deep. I think that is the best way to go. Another point I want to mention is if the vertical space is lacking, there are many benefits to tissue level implant. But despite this, bone level implant are more favorable in that case. Thank you. Thank you for the wonderful response. There's a lot of questions on the real-time chat screen. A lot of questions have been raised on your lecture. Let's take a look. Lala, I've come to watch the program live. Thank you. ID 열공맨, I want to get coffee coupon today too. Thank you for leaving words of support. Let's move to questions. I've noticed a lot of questions. LEE74NEN. What is the most important in doing occlusal adjustment on prosthesis? I think it's related to occlusal adjustment and is slightly out of context because the professor's lecture is on design. We'll take a look at that later. Happy day. What is the appropriate size of proximal contact in terms of buccal, lingual, and occlusal gingival direction? It's defined in the textbook. It's not different with the implant prosthesis as is with natural tooth. Height, occlusal third, it's a must. Occlusal third in terms of height and buccolingually. Normally it's in the middle. In the upper, the palatal cusp is the functional cusp. It should be inclined towards that. And in the lower, buccal cusp is functional cusp. The proximal contact should be slightly buccally inclined. I think that's good. It's the same with implant. The surface, it may vary depending on tooth. As for implant, we need to consider interproximal contact loss or ICL. Therefore, rather than point of contact, we need to consider surface contact. LEE74NEN. The emergence profile. Physiologically, having a straight cuff, is it recommended? In other words, if the angle is straight, will it prevent a lot of problems? Comparatively, there's less problem. Food impaction or stress on the soft tissue. This occurs less with a straight type. That's my opinion. The next best is concave, and convex is not recommended. Yes, in my opinion, I believe so. Summer, implant placement position is very important. What is the recommended placement depth? I think it depends on implant type and company. The concept used in making implant body differs, so recommendation differs. As for bone level implant, I place it 1 millimeter deeper. The benefit with that is after surgery, there's a physiological resorption. It compensates for that. Platform switching is possible these days, and resorption does not occur inferiorly to the implant. Even if you place the implant, bone loss does not occur significantly. A lot of our predecessors recommend placing implant deep is recommended. By doing so, the alveolar bone may provide protection against the bacteria from the implant. So placing it 1 millimeter deeper. People sometimes say placing it even deeper is recommended. In general, I place it 1 millimeter to 1.25 millimeter deeper. IDIR. If the implant is placed mesially inclined, the mesially adjacent to tooth's space can be formed, significantly leading to more food impaction. How about we reduce the space via forming contact surface rather than contact point by adjusting the mesial side of adjacent tooth? I've never tried this. As mentioned, when implant is mesially inclined, there are many problems. You have suggested adjusting mesial surface of adjacent tooth. However, if you do this, the mesial form of that tooth is changed. Physiologically, this will not be good. I believe we need to address that using the implant side. You need to adjust the abutment. I'm not sure whether this answers your question. I think it's a good answer. Paul Test, you really have good pronunciation. I can really hear what you're trying to say. I wish we could continue on with the questions, but the professor needs to continue on with his lecture. We will entertain more questions after the lecture. Next, I'm going to talk about the occlusal surface as well as buccolingual contour. In this case, the implant was placed by the resident. The resident graduated and I completed the prosthesis. I thought that this was problem-free. While I was following up with the case, I did not detect this issue. About 2.5 years later, buccal side of number 36, perimucositis occurred. When I removed the prosthesis on the buccal sulcus, there's food. I cleaned it and did oral hygiene education once again. The patient was excellent in maintaining oral hygiene, but I still wanted to blame the patient a little bit. 6 months later, it's not clean again. You can see microfistula here. When I removed the prosthesis and abutment, the food is significantly impacted. This made me realize that my prosthesis was the problem. I removed the prosthesis and looked at it carefully. Those who have learned ahead of me, you may have learned the gingival protection theory. The height of contour, which is gingival third of tooth or prosthesis, the height of contour prevents food from falling into the sulcus. So it does not irritate the gingiva and is not impacted in the sulcus. This theory was first introduced in 1920s and was accepted in 1970s. But since then, there were controversy over the scientific evidence. And if you control too much, periodontally, there was problem. So the power of the theory was reduced significantly. However, in this case, I think this theory rings true. If you look at the occlusal surface, it is almost like edge-to-edge type. occlusal surface and height of contour are in a straight line. So the height of contour is not preventing food from falling from the occlusal surface. So it goes into the gingival sulcus. So if you look at the form of food impaction, it's not gathered, it's impacted, it's stuck in the sulcus. So I think a gingival embrasure being small was one problem. Subgingival margin and gingival embrasure lacking, this was a problem. I decided to make the prosthesis once again to open the gingival embrasure like this, and by doing so, I made a supragingival margin like this. I moved the occlusal table lingually and at the same time, I decided to enhance the cervical third of height of contour. This is the prosthesis that resulted. If you look at the occlusal table, this has been lingually moved in line with the antagonist. The height of contour has been accentuated. At the same time, the gingival embrasure became enlarged and supragingival margin was formed. This was delivered. This is 6 months later. The patient said the odor disappeared. Soft tissue has improved significantly. If you look at the gist of this case, the occlusal table and height of contour, the gingival sulcus, if they are aligned in a straight line, the crushed food can move into gingival sulcus, and this can be easily impacted within gingival sulcus. The soft tissue sealing of implant is much less than that of natural tooth, so this kind of phenomena can occur very easily. To provide you my opinion on buccolingual control of implanted prosthesis, if the alveolar bone is thick and soft tissue thickness and height is sufficient, you need to place a wide diameter implant and provide large diameter abutment so that you can provide a prosthesis that resembles natural tooth with a similar occlusal table and height of contour. This case falls under this category. If you make a prosthesis similar to that of natural tooth, patient satisfaction will go up and oral hygiene will be easy to maintain. Gingival embrasure, it's normal for it to be larger than natural tooth. The patient has abundant alveolar bone and sufficient keratinized tissue. You need to make your abutment and prosthesis that resemble natural dentition. The problem, as is always, is with atrophied alveolar bone. Even if the patient has atrophied alveolar bone, if the patient has will, you can do surgery to make the situation improve and provide prostheses that resemble natural teeth, but this requires effort both on the part of the patient and the surgeon. You need to do both significant bone graft first and place a thick implant like this, and soft tissue needs to be improved. Sufficient alveolar bone means not just a thick bone, but it also means a thick keratinized soft tissue. Soft tissue needs to be managed. When flap is reflected, we need to compensate for the lost vestibule. We need to regenerate it. I'm sorry? As shown, we need to regenerate it. When we make occlusal table and contour that resemble natural teeth, food impaction will not occur easily and the food will come back up as shown. If the patient has atrophied ridge and if you want to make prosthesis similar to natural teeth, you need to put in a series of effort. If the patient does not have will or does not fall into this category of treatment, we need to inform the patient of limitation of implanted prosthesis. We should not overly focus on surgery. We need to compromise for atrophied ridge. For atrophied ridge, soft tissue is basically lacking. If you use big abutment, soft tissue can be stressed and it can be deviated drastically. Gingival recession can occur very easily. You need to use a little bit smaller abutment. In the case of atrophied ridge, if you use big abutment, in this area, undercut is bound to occur. For atrophied ridge, you need to use abutment with a small emergence angle. The problem with that abutment is how are you going to design the contour of prosthesis and occlusal table? That is the key. You need to consider various variables as shown and choose one with comparatively less problem. If you use a small abutment and make height of contour and occlusal table that is similar to natural teeth, then here food impaction is going to occur. If you use a smaller abutment with smaller height of contour and make large occlusal table that is similar to natural dentition, the crushed food is going to irritate gingiva or is going to be stuck. I think this is the only option we have. For atrophied ridge, you need to use a smaller abutment and a reduced height of contour and slightly reduced occlusal table. This is the best compromise that we could choose. Let's look at the image. If you make prosthesis like here, food impaction is going to occur here. Or if you make it like this, height of contour is not going to function and food is going to be stuck within the sulcus and food impaction is going to occur. In the early days of implant placement, we made occlusal table and height of contour reduced. The food will not be impacted. However, because occlusal table is too small, the antagonist relation is going to get worse and patient satisfaction is going to drop. But because of reduced height of contour, patient's sense of mastication will drop. In this case, there will be reduced cheek support as well. For atrophied ridge, my recommendation is to use a smaller abutment and reduce the height of contour and smaller occlusal table. So by smaller, how much smaller? I think occlusal relationship is very important. I don't want to get rid of cusp-fossa relation. If you look at the occlusal table, we need to do it within the scope of cusp-fossa relation of the upper and lower, and occlusal table needs to be minimized as much as possible. Height of contour, where function is possible in occlusal table, need to be made. Occlusal table and height of contour is approximately 20% reduced. If you look at the prosthesis on left and right for atrophied ridge, the right side is much more attractive for patient in terms of function and aesthetics, and it's quite good for oral hygiene as well. I'm going to conclude my lecture by summarizing. In the beginning, I talked about how there are many concepts of prosthesis and abutment design. The reason is because the patient's oral cavity can accommodate different designs. It can accommodate different designs and forms. However, we need to be aware of the cases where it is prone to issues. We need to learn of this. And clinically, we need to make sure that we avoid such situations. In order to do so, I believe implant placement position, depth, and inclination are still very important. We need to think long and hard how to restore the masticatory function of the patient and prevent the food impaction and to ensure good oral hygiene. This needs to be considered for every case. I believe with that, you'll be able to provide successful treatment. Biological complication. This occurs for everyone in some cases. Biological complication is very different from mechanical complication in that it comes very quietly. It may be cumbersome, but we need to follow up with every patient and periodically do checkups to prevent the biological complications. I believe it is very important to detect these problems early on. Based on my experience, when you find these problems, you should not be so conservative, but be more active. You can try to remove the prosthesis and, if necessary, improve the prosthesis. This would be better long-term for both patient and surgeon. So this is the end of my lecture. Thank you for listening. Thank you, Professor, for the wonderful lecture. I was really infatuated. It was meaningful. The chat screen, there are many comments. Avid responses can be observed. I believe we'll not be able to answer all the questions, and I believe you may have to answer individually. LEE74NEN. The keys that you're showing, I think you need to adjust the occlusal level of antagonist and refabricate the implanted prosthesis. I think this person was looking at a different case, but I really agree. If the antagonist is extruded, you need to adjust it, and then implanted prosthesis needs to be adjusted accordingly. Thus, when placing implant, in order to minimize mesial undercut, you need to place it as much close to the adjacent root. What is the optimum distance which does not get too close with the adjacent root and minimizes occurrence of undercut? So the distance when you place the implant. It's very difficult to pinpoint a number. I tried to place it close rather than apart. I really agree with Nas. It is better to place it closer. The emergence angle becomes better, but if you get too close, accidents can occur. We all know this, but the distance between implant and root needs to be at least 2 mm from the exterior wall. But I believe it is still better to be closer. If there's teeth mesiodistally, I think it is best to place it in the middle. I'm talking in the sense when we're placing the most distal tooth. When you look at the interns, because it's their first time placing implants, so they try to place the implant apart from adjacent root. When you look at the placed implants, so you can easily tell if a beginner has placed it. Closer is good, but it needs to be at least 2 mm apart from the exterior wall. What is important is that when you place the implant, your wrist should not get bent or else it will be tilted. You need to make sure your wrist is straight when placing the implant. ID smile again. Professor Jovino, Professor Sojemi, nice to meet you. Thank you for the wonderful lecture. TS is related to abutment. How big should the implanted crown be compared to natural tooth in terms of percentage? About 20%. This was mentioned earlier? Yes. As mentioned, you can make the prosthesis similar to natural dentition if the alveolar bone condition as well as soft tissue is good. You can place thick implant, yes. In that case, however, in atrophied ridge, we cannot forget about intercuspal relation because satisfaction regarding mastication goes down significantly. In the past, when we emphasized implant-protected occlusion, people said that there should only be contact in the central occlusal surface. However, these days, we don't do that anymore. Contact is made better if you focus on the intercuspal position based on my experience. From the fossa, you need to make it as close to the outer side as possible because fossa is also a facet and you need to reduce the overjet. Then you'll be able to reduce by 80%. Understood? LEE74NEN, you have really raised a lot of questions. how deep should implant be placed? So you talked about how placing implant deep. Yes, 1 to 1.5 millimeter. Up to 2 millimeter, yes, I believe that's okay too. I think that'll be sufficient. There are people who place it deeper. For find, in general, is there a recommended abutment size for different teeth? If there is a healing abutment size, please tell me so. I receive a lot of questions like this, but it differs from patient to patient. And we need to consider the thickness of soft tissue as well as alveolar bone condition and the intercuspal relation. It's quite difficult to say, but personally, if it is atrophied ridge based on healing abutment, I don't think it should exceed 5 to 6 millimeter. This is just based on my experience. The diameter of healing abutment, not the length. I think it also differs depending on the length because the angle differs. If the height is 5 millimeter in atrophied ridge, it should not exceed 5 millimeter, but it may differ depending on the soft tissue thickness. 3992875. Does bone loss occur due to food impaction? Is the primary cause due to food impaction? I think there are multiple reasons. It's not just because of food impaction. I think it starts with the inflammation in the soft tissue level. There are cases where food impaction occurs up to that point, but in most cases, it is expansion of inflammation. Cross BMS. If the adjacent teeth are worn and if crown height is insufficient, do you place implant deep to get appropriate emergence angle? Do you prep the alveolar bone to reduce the bone level? Even if you do that, I believe the gingival embrasure space will become bigger because of the difference with the adjacent teeth. As mentioned, I think we need to prep the alveolar bone to reduce the bone level. Primary stability may not be good in this case, but this needs to be overcome with your technique. What is more important is to prep the alveolar bone to reduce the bone level. I'm not really sure about the second question. So if you reduce alveolar bone too much, it may be a slope with the mesial tooth. I do not believe so because we do not prep significant amount. I think 2 to 3 millimeter at most and place the implant so it will not be a problem. It will not be problematic for cleansing as well. This is for patients with lack of vertical space, so it's okay. ID rainbow. If the vertical space is limited, which do you believe is better? External type or internal type bone level implant? There's no major difference. There may be difference with the tissue level and bone level implant, but I do not believe there's major difference in terms of external or internal connection. There's no major difference. Kukdas. You have talked about a natural transition from abutment to prosthesis. In general, in posterior implant, which do you recommend more, 5 millimeter or 6 millimeter coping? Is bigger more favorable? If the soft tissue thickness is good and has good contour and has good bone, it would be better in terms of form to use 6 millimeter. However, when placing the implant, if you use a thick implant, the amount of prep becomes increased. You need to do drilling in a careful manner. We'll entertain 1 or 2 more questions. There are so many questions. Professor Seo, you definitely need to come once again because there are so many questions. I will reply them if I can't today. Prosto Daegyun, thank you for the wonderful lecture, Professor. When I use platform switching in internal type implant, Will it affect the contour of prosthesis and lead to negative profile? If you do platform switching, the angle becomes more drastic. Yes, there are pros and cons in using this. Platform switching can be done for both external and internal type. It's not a matter of internal or external, but if you do platform switching, emergence angle becomes more significant. Therefore, in that sense, it's quite negative. However, it has advantages too. There's less bone loss below the platform, and you can also secure soft tissue thickness. There are advantages as well as disadvantages. As you have mentioned, in terms of emergence profile, it can be disadvantageous, but clinically speaking, there are more advantages. So advantages outweigh disadvantages. Morphologically, it can be disadvantageous, but biologically, thinking of gingival condition, there are advantages. So it's difficult to say which is bad. There's pros and cons to this. We'll entertain one more question. Impl, if there's a lot of horizontal bone loss and if you cannot place implant deep, in order to increase the life of prosthesis, what kind of biological considerations should be considered? Should I make the abutment neck thin with smaller taper? If implant cannot be placed deep, when designing the abutment, should I choose a thinner neck? So this is a very unfavorable situation. There are many cases like this. Yes, abutment neck. The taper needs to be reduced. Occlusal table and contour needs to be in line with this. And I agree with you, ID Impel. Professor Seo's lecture has been very clear, therefore, I believe that's why there are so many questions. Happy day, Yeonji-shi. In the case of ID Yeonji-shi, this person is a true avid viewer of prosthodontics on Friday. The answers that were not answered today, we'll deliver them to Professor Seo, and Professor Seo will provide an answer. Your support will be deeply appreciated. There are many questions. There are so many questions. I feel bad for not being able to address them all. Some people may feel disappointed that their questions were not addressed during the lecture today. I apologize. We are nearing the end of our time, therefore, maybe perhaps next time we'll start with questions at the very bottom and change the order. We try to address all the questions, but the time limit is set as 1 hour. I apologize once again for not addressing all the questions. Next time, we will try to address them all. I would like to express my gratitude to those who have participated in the chat. Now, Professor Seo, could you please choose the best question out of all the questions raised in the prosthodontics on Friday? I want to choose the person who's raised a very difficult question to answer. Proso Daegyun, who have asked a question regarding platform switching. Will it affect the profile negatively? That was the gist of the question, and I would like to give coupon. I would like to give coupon to everyone. Yes, I agree. I wish I could do that too. Prosto Daegyun, congratulations. We will send the coupon via text on Monday. The coupons will be sent then. I'm sure you have agreed to marketing. If you do not agree to marketing, we cannot send you the coupons, so please agree to marketing and get your coupons. Thank you. Live chat event continues in the next lecture, so I look forward to your keen interest. Professor Seo, thank you for the wonderful lecture and staying with us up until late. Is there a word of advice you'd like to give to your peers who are studying up until late in Friday night? I really admire dentists who are studying up until late. I would like to give a round of applause to your passion, and I would like to give words of support. Thank you for spending time with us despite your busy schedule. Viewers of Prosthodontics on Friday, did you enjoy the Prosthodontics seminar with Professor Seo Jae-min? I believe this was a meaningful time to get tips on abutment design and in reducing biological complications related to implant placement. The answers that were not addressed today will be answered via reply. Dr. Park Jong-hyun of Seosanduri Dental Clinic will talk about hex and non-hex abutments pros and cons. Thank you for watching. Thank you for asking your questions. Thank you.
선생님 수고하셨습니다.